Good morning, everyone. Welcome to the March Sexual Health. Oh my goodness, I'm so sorry. The March Sexual Wellness Professional Development webinar hosted by the Centre for Excellence in Rural Sexual Health. Tongue-tied this morning. I wanted to begin by acknowledging the traditional owners of the land on which we are on. Wherever we're zooming from around Australia, we are on Aboriginal land that has never been, sovereignty has never been ceded. I want to pay my respects to elders past, present and emerging, and also extend that respect to any First Nations colleagues that are joining us today. It is my pleasure to introduce Professor Jane Tomnay, who is the Director at the Centre for Excellence in Rural Sexual Health and our guest speaker today. Thank you for joining us, Jane.
Thanks, Ash. I'm just sharing my screen. Thank you very much for inviting me to present today. So today I'm going to talk about partner notification for sexually transmissible infections and HIV and bloodborne viruses. So I hope that you're happy for me to refer to sexually transmissible infections as STIs and HIV and BBVs, which is bloodborne viruses. So the purpose of the presentation is to perhaps introduce the concept or remind people about the concept and its role in control of STIs and HIV, and also to explore partner notification from both a public health perspective, but then hopefully for the second half of the talk, we'll be able to give you some practical advice around working with individuals who are being asked to carry out partner notification. So this is a voluntary process, and I underline voluntary, to notify the sexual and or injecting partners of a person diagnosed with an STI or a bloodborne virus and advising them that they've been exposed. So partner notification processes should also provide support and assistance to those people that are contacted, those partners, in ensuring that they can get access to testing, and if they tested positive and require treatment, that they're able to get that as well wherever appropriate. So just to mention, partner notification is not legally required in any state or territory in Australia, but we do believe that there is a duty of care to professionals diagnosing people with an STI to assist that patient to carry out partner notification. There have been court cases in Victoria many, many years ago in the early days of HIV where partners have taken legal action against a doctor who has diagnosed an index patient with HIV and have not made efforts to contact their partners when they were provided with information. So that's just something to keep in the back of your mind. It's not a legally binding process, and we'll talk about the reasons for that as we go through this presentation. I don't know why my slides aren't moving, sorry. Can't get them. Oh, there we are. I'm sorry about that. It's important to do partner notification because if there's one thing that we can't be argued, and I have said this many, many times to patients that I've worked with, is that you can't have a sexually transmissible infection on your own. There's always at least one other person who has the STI because you have acquired it from someone, and there may be somebody else that your patient has inadvertently placed at risk or transmitted the infection to. So why do we do it? So there's public health reasons why we do it. We look to interrupt the transmission of infectious diseases, and everybody would be well aware of that, having just lived through the COVID pandemic. But it also helps us to identify particular populations that might be at greater risk. And also the ultimate aim of partner notification is to reduce the community incidence of a given infection. But from the individual's perspective, what do patients gain from this process? So what we're trying to do is prevent the development of serious complications in infected people wherever possible. So if we think about STIs, we know that most of the STIs, and if we include HIV as well in that group, most are asymptomatic, or there are a lot of patients who don't know that they're infected. And unless they're alerted to that fact, then they don't seek testing and therefore can't be treated. So if we leave, for example, chlamydia untreated, then we do know that that can cause some serious complications, particularly for women further down the track. Things such as PID, ectopic pregnancy, and so on. So it's very important that people are alerted. We also know that from a public health perspective, that the number one thing that drives individuals in Australia to seek healthcare are symptoms. But when we think about STIs, we know that a lot of people don't have symptoms or they don't recognise symptoms. So we're trying to do that. We're also trying to prevent patients who are asymptomatic, who are infectious, from accidentally or inadvertently passing the infection onto subsequent sexual partners. So we're wanting to interrupt that onward transmission. And then it also gives us an opportunity to provide individual counselling and support to people, to talk to them about their sexual behaviour and to talk to them about ways that they might be able to minimise risk activities if they choose to. So again, I'm hoping people will be familiar with Roe, Anderson's Roe. This is the likelihood of an epidemic continuing in a susceptible community. And there's 3 factors that go into calculating Anderson's Roe, and they are the probability of transmission within the sexual relationship. And that's really talking about how infectious the actual organism is. There's not a whole lot we can do about that because each organism has its own infectivity rate. The rate of new sexual partners of the infected person and how many partners they have in a given particular period of time. Again, there are people that would argue that given human nature and human behaviour, it's very difficult to impact and change the way that people meet sexual partners and how often they change and so on. And then the third factor is the average length of time that a person is infectious. And this is the part of this equation that we can really impact the greatest, and that's where partner notification comes in. So if we think about people who have been infected with a STI, they're asymptomatic and they don't know about it, if we can notify those partners quickly, then we can get them to testing, we can diagnose them and we can treat them as quickly as possible. And that means their length of time that they have to inadvertently transmit to susceptible partners in the future is shortened. I hope that makes sense. So I thought what I might do today is just explore with you or describe to you partner notification from an international public health response. It was something that I was involved in Indonesia just prior to the pandemic, and it's using HIV as the example. So if we look at this slide, people may well be familiar with, this is 2015 data, and it has been more recently updated, and we call this the 90-90-90, and these are the WHO goals to control global transmission of HIV. They are now the 95-95-95 targets. But if we look at these data, it's estimated that only within the global gap in achieving the 90-90 target in 2015 was that we believe that there was around 11.9 million people who were infected and living with HIV on this planet who didn't know about their infection. There were 12.7 million people who needed antiretroviral therapy and didn't have access. And there were 13 million people who were living with HIV who were accessing antiretroviral therapy but weren't virally suppressed. And the reason that these targets are really very, very important is that that first group that you're looking at, 57%, that's what's estimated in Indonesia too. That's the number of people who are estimated to know that they've about their infection status with HIV. So that leaves us 43% of people with HIV who don't know that they're positive. So if they've never been tested or never been diagnosed, then they can't get access to treatment. Once they're tested and diagnosed, they can get access to treatment and they get antiretroviral therapy. And the aim of that therapy is to virally suppress the HIV in that person's system so that their viral load is what we call undetectable. There are so few virus in a ml of blood that it's difficult to count them, less than 50 copies usually. And the reason that that is important is that when people are taking antiretroviral therapy and they are virally suppressed, that means we can't find the virus. Tests aren't sensitive enough to pick up very, very low numbers of virus in their blood. We know that they cannot transmit HIV to another person. So that's the aim, is to get 95% of people on this globe diagnosed on antiretroviral therapy and virally suppressed. So what they found in Indonesia was that the current HIV testing services approaches were not going anywhere near enough to get to the 90% of people they thought were infected. And they showed that more testing didn't equal diagnosis of more people with HIV or them being identified. And they thought that partner notification would be an effective strategy for identifying new cases of infection. Sorry, I can't get this to go forward. There we are. That's just a quick photo of me with my colleagues from WHO in the Jakarta office just before we started a long group of workshops with HIV physicians. So the HIV epidemic in Indonesia was concentrated among key population groups. And as you can see, they're very similar to the key population groups that we see here in Australia as well. They believe that those populations made up about 30% of the estimated people living with HIV in Indonesia in 2017. And the remaining 70% were either from non-key population groups, had previously been members of the key population groups, were people who didn't disclose their behaviour risk, as well as the intimate partners of those people who were living in those key population groups. So in 2013, the Indonesian government decided to really scale up HIV testing services across the entire population of Indonesia. And they were concentrated on improving access to testing in the hope that they could get closer to that very first 90 target, that they could get 90% of people with HIV diagnosed. They brought out some very innovative programs. They set up pop-up testing sites in train stations, in big bus terminals. They knew very much about how their population moved, particularly during the day. And so they would set these testing sites up first thing in the morning when people were commuting to work. At the end of the day when they were coming home, they set them up so close to high schools so that young people coming out of high schools could get tested. They really worked very hard at getting more of the population tested. And what the result of that was that they doubled the number of tests that they were doing per year. So they went from 1 million tests in 2013 to 2.5 million tests in 2017. But the problem was that whilst they spent so much more resources to test people, they didn't find any extra people living with HIV, or they found that there wasn't that many extra people who knew their status. So they estimated that about 280,000 people were diagnosed, but they knew through some mathematical modelling that there was approximately 630,000 people living in Indonesia who were positive. So what went wrong? And one of the things that we talked about was that the testing wasn't targeted enough. And we were able to show this when we looked back at the tests that had been undertaken in those 2 years and looked at the laboratory results. And what they found was there was a lot of people who were repeat testing. So they went out and did some focus group work and spoke to, for example, this is just one group, but they spoke to a group of women who were of childbearing age who tested, women who tested more than 10 times over that 2-year period and had 10 negative results. And they asked these women why they were repeatedly testing every month or every couple of months. And the women said that it was their way of trying to determine whether or not their husbands were faithful to them. And so obviously these women who were repeatedly tested and found to be negative were not at risk, but they were using the resources of the testing facilities. And then the other side of that coin was that people who were tested through these programs and found to be HIV positive, there was some level of lack of trust in this government program, and people then went from testing site to testing site to check and to try to retest and retest in the hope that one of these tests would eventually come back negative. Now, those of us who know a little bit about how HIV testing works is that you're looking for antibodies in the person's system at this time. And so once the test turns positive, it will always be positive. It will never resort to negative, except in very, very few exceptional cases in the world. So they were spending, again, lots of money testing positive people, but it was the same people over and over and over again. So they weren't targeting the people they thought they needed to. Excuse me. So what we did was looked at how best we could set up partner notification services throughout Indonesia and what we needed to do in order to build the service system. The very first thing that we knew was that we needed to build workforce capacity, and we needed to improve the skills of people who were going to be providing some of this partner notification. And that's where I did some work with WHO in Indonesia, and we held a week long of workshops in Jakarta. I then went out to clinics and were mentoring clinicians in their local clinics. I also worked with peer groups and we worked very strongly with WHO and with the health department in Indonesia to ensure that they engaged peer support agencies and peer leaders, and we trained up peer leaders. So particularly in MSM communities, men who have sex with men, and also in commercial sex work communities. We also engaged with people who were living with HIV for them to also talk with these NGOs and start conversations as well. Then subsequently, we brought a team together and brought them back to Australia, and they spent some time with me here in Melbourne in Victoria, and we spent a couple of weeks looking at how the Australian system was set up. And I had been integral in setting up that system many years ago at the beginning of HIV, and worked myself as a senior contact tracer for 15 years. And we then also took them to Sydney and spoke to folk in Sydney around how it looks different in New South Wales, but was still just as efficacious as it is here in Australia. We also encouraged them to build place-based local responses, and I used here a lot of the learnings that I've had in working in regional and rural Victoria, because as you can imagine, there's a lot of rural communities in Indonesia, and we looked at using local expertise, talking to local people and community development principles, and we leveraged on successful programs of the past. And throughout this time, we also built in a system of continuous evaluation and improvement. And I worked with a colleague from the University of Washington, and he really ran that sort of side of the program. Then the pandemic hit, and subsequently I've been working, still mentoring clinicians, both HIV physicians, general practitioners and nursing staff. And we do that over Zoom. They periodically bring their what they consider difficult cases, and we workshop them together through Zoom meetings. So that sort of gives you a bit of an idea of how partner notification can help from a public health perspective or from a population-based perspective. But now I wanted to concentrate a little bit on individuals, and I wanted to talk more around pragmatics and hopefully give you some practical hints if any of you find yourself in a situation where you need to support somebody who's undertaking partner notification, or you're actually doing it yourself. So there's 4 different ways that we describe partner notification in the literature. The first is what we call patient referral, and that's where the index patient is the person who has been diagnosed with the STI or the bloodborne virus, where they agree to inform their partners themselves of the risk of STIs or HIV infection. Now, as you can imagine, this is a very cost-effective, cheap mechanism to use. So it's used primarily throughout the developing world, and we use it almost entirely here in Australia for infections such as chlamydia. So we say to the index patient, you've got chlamydia, this is a sexually transmissible infection. Do you have a current sexual partner or a recent past sexual partner? Are you able to tell that person? Now, most patients say yes. The difficulties, or one of the limitations with this process, is that we don't always know if it's done. We have to rely on what our patients tell us. And it's very, very difficult to evaluate these strategies because of the way that our health system is set up, and also around the issues that we have where we need to maintain people's privacy and confidentiality. So the second way that it can be done is that a healthcare professional can do it on behalf of the index patient. The advantage of this is that the index patient remains anonymous to the partners, and we tend to use this for HIV in Victoria in some instances when patients ask for us to do that. Every state of Australia have professional partner notification officers or contact tracers, or people within their local public health units, or people within health departments who you can refer difficult or complex cases to if you don't have time to help your patient yourself. And so this is where the index patient provides the contact details of the partner to the health professional contacts that partner and lets them know that they've been at risk of whatever the STI is or HIV. This is a very, very expensive way to carry out partner notification. However, it does yield the greatest number of partners notified, and I'll show you the evidence shortly. Then we have what we call conditional or contract referral partner notification. I did partner notification for 15 years, would have followed up thousands and thousands of partners, and I don't ever remember using this strategy ever. We use it very rarely in Australia. I can't find any literature that actually describes cases, but this is where the healthcare provider makes an agreement with the index patient and they set a time limit. So we say to the index patient, will you contact your partners? The patient says yes. The provider says, okay, I'll give you 2 weeks to do it. If it's not done within 2 weeks, then I will do it on your behalf, and ask the patient to agree to that. And it may be 2 weeks, it may be 4 weeks, it may be 1 week, whatever's negotiated between the healthcare provider and the patient. Often when patients say that they'll do it themselves, they do it themselves when they can find when they know who the partner is. And the final strategy is what we call dual referral partner notification. And this is where the index patient and the healthcare provider do this partner notification together. I used this strategy many times when I was contact tracing for HIV, and a classic sort of case that I'll describe to you is when we would diagnose a man with HIV, and when I would take a sexual history from him, he would tell me that he has sex with both men and women. He has sex with men, and he is married to a woman. However, his wife, his female partner that he's married to, does not know that he has sex with other men. So using provider referral, if he had provided to me the contact details of his wife, it's not the appropriate strategy to use, because if he is her only sexual partner, then it makes it very obvious when you contact her to say that she's been exposed to HIV. She will know who the index case is anyway, if she's only had one sexual partner. And we would explain this to patients very clearly and say, look, that's really not the best way to go. Far better for you to ask your partner to come and attend the health service together, and then together we will sit down and we will give her the news. I can answer the questions that she might have, or any sort of clinical questions, and you can answer any of her other questions if that suits you. And patients usually agreed that that was probably the best way to handle those situations. So in Australia, as I said, we encourage patient referral partner notification for most of the bacterial STIs. So we would encourage it most strongly for chlamydia and also for gonorrhea, where patients know that have some details about partners and how to contact them. But it is the healthcare provider's responsibility, and we would expect them to at least raise the issue with the index patient, and not just raise the issue, but also provide supports and information that motivates that patient to carry out the partner notification. We know through studies that we've done in the past that by saying to a patient, I'm diagnosing you today with chlamydia, it's a STI, you need to tell your patient that's not enough to support that patient often to tell that partner. In most cases, yes, they will tell the partner if they're a current regular partner, but that's not enough to encourage them to contact past non-regular or casual partners usually. And we mostly use provider referral for serious bloodborne viruses, including HIV. Sometimes these days we also use it for infectious syphilis, because syphilis can be a little complicated when you're testing people. So sometimes it needs people who know what they're talking about and doing to be able to provide the correct information to the partner. And as I said, there are professional contact tracers in each state where you can refer your index patient to, and they will contact partners on behalf of that index patient, allowing the index patient to remain anonymous to the partner. So, for example, if we think about a person who has just found out themselves now that they've been diagnosed with HIV, particularly in smaller communities or in those key population groups, they can be quite small, and people worry that everybody knows everybody. If we think about small rural communities, or we think about small networks of men who have sex with men, or particular people from different ethnic backgrounds who may well socialise and have sexual networks within those communities, they worry that if I go and tell an ex-partner or a past partner that I've recently been diagnosed with HIV, that they need to go and get themselves tested, then everybody in the community may find out, because that partner might tell other people that I have HIV, and then I may be exposed to stigma related to that. So one of the benefits of having the health professional do it on that index patient's behalf is that under no circumstances do we ever divulge any information about the index case to the partner unless we're legally bound to do so, and that's in very rare instances. So I thought just very quickly I'd show you some evidence about what it tells us about how these strategies work. So we know that partner notification can improve the control of HIV among men who have sex with men, particularly if we use provider referral options rather than patient referral. And the second study there we did many years ago now in Australia, but it has been replicated. We found that sending every single client in an opt-out referral system rather than an opt-in to speak with professional contact tracers when they were newly diagnosed resulted in many more partners being contacted. We also know that provider referral partner notification leads to more partners being notified compared to just asking patients to do it. There's many studies that repeat this and find the same findings. I explained why before, but just keep in the back of your mind that this is a developed world program. There are very few countries in the developing world that can afford to have comprehensive provider referral partner notification programs. And then this is a study that I did some time back now, 5 years ago, with Australian men who I interviewed men within 3 months of their diagnosis and asked them what it was like for them to notify partners themselves, those that had chosen to do so. They said that they were fearful of undertaking partner notification, and they were worried about disclosing their own HIV status. They had unexpected reactions from their partners, and they also needed more support to be able to do it themselves. So they said they found it difficult and uncomfortable, and they described that they had fear about potential repercussions, like what will this person think? However, it was very interesting that almost all of them, it was a very strong theme, felt that it was the right thing to do. When they were offered provider referral assistance, they really only did that in a small proportion of cases. Most of the time they thought, no, they would do it themselves. And that was for both casual and regular partners. But of course, regular partners were much more likely to be notified. They're much more likely to have information that allows them to notify regular partners in person and so on. And they much preferred to do it in person because they found that that was probably, they felt that they were morally responsible to do that. They very commonly had very few, if any, contact details for casual or one-off sexual partners. And if they did, they preferred to use strategies that allowed them to remain anonymous. So the more distant the partner was, or the less known to the index, the less likely the index was willing to contact that person themselves. And the unexpected responses that they got from the reactions that they got from partners, most of these men said they expected for the partners to be annoyed or angry, or they were concerned of their reaction, but pleasantly, they almost all of them found that they got a positive response from the partners, either thank you very much for letting me know, but more often than not, the partner's asking, I'm really sorry to hear that you've just been diagnosed with HIV. How are you doing? Are you okay? Have you got people around you? And so on. So that was a really nice, unexpected finding. Then again, we did another study, and this has been repeated since, and same results found, asking healthcare providers what are their concerns about carrying out partner notification. And these were some GPs that were interviewed. They worried about having not enough time. What if they didn't have contact details? Really interestingly, they were quite a large proportion of these GPs that were interviewed that were worried about whether or not it was legal to contact partners and whether they were breaching their own patients' confidentiality, which showed really that they didn't understand how partner notification works. Because if you remember, I said that we never, ever tell the partner anything about the index patient. And they also said very clearly that they felt both personally uncomfortable, but also that they had inadequate training to be able to do this work. So let's now move on, and we'll talk a little bit more practically about partner notification. So I'm going to use a patient with chlamydia as my first example. These are the basic principles of partner services. So remember that it's always confidential. It's got to be non-judgmental. The services have to be accessible. We can't charge people for this service. It's always got to be free. And when we talk about comprehensive and integrative, we're talking about ensuring that not just for partner services to work, we can't just stop at the point of letting the partner know that they've been at risk. We need to ensure that we've got wraparound supports that we can provide that partner also with information about where they can get tested, where is locally or, somewhere where they prefer to get tested, and to ensure that those testing services are available, flexible and accessible from a cost perspective, logistics and so on. And then also we want to know that partners who are contacted, who do present for testing, if they are found positive, that they do have access to treatment. Otherwise, contacting people, it has no public health benefit if those partners can't get into services to be tested and treated. So remember that interviewing is always at the centre of partner services, and you've got to remember all those really good communication skills that we're all taught. Remember that patients who understand that treatment's important for their own health are much more likely to provide information about their partners or to tell partners, because they also understand that it's important for partners to be treated. So particularly if your index patient is a young person with chlamydia and they're asymptomatic, I would often say to them, well, you know, you didn't know that you had this infection until you had the test, but it's a very common infection. It's very easily treated, and we can give you these antibiotics and you can be treated and the infection will clear away within 7 days. So if you can let a partner know, then they can also get the same treatment, because if you think about yourself, you didn't have any symptoms, you might have accidentally passed it to someone else, and your other partners may be doing the same thing and not know. So what we're trying to do is to interrupt transmission, so everybody who is at risk needs to know so that they can get tested and treated. Then again, it's also very, very important to listen to patients' fears and concerns, especially in relation to intimate partner violence. There's lots of studies that have come out of the US that show that particularly pregnant women with an HIV diagnosis are at much, much higher risk of intimate partner violence when they inform their regular partner of their HIV diagnosis. So it's very important to listen to your patient's fears and concerns and to take them very seriously. So if I saw a patient that was very, very concerned that they would be physically, psychologically, sexually, or in any way harmed by carrying out partner notification, then I would stop the process there and then and say to them, we need to find a way that we can still do what we can for public health, but your safety and my responsibility to you as my patient is foremost. So looking after the index patient in the first instance, and then looking at ways that perhaps the partner can be notified in a different way. And some common examples of that was that we would say to, particularly if somebody had an order against a ex-partner, that the partner wasn't allowed to come within a certain time of them, a certain distance of them, or they weren't allowed to contact them, or so on, if there'd been previous violence or other issues in the past relationship, we would say to them, look, give us that person's details. We will contact that person, but we won't do it for a specific period of time. So leaving a little bit more time so that there's a bit more distance between our index patient and the past partner. And then we would be extremely careful about any information that was provided to that partner. And we would also let the index patient know that we were going to contact the partner. So we would let them know, you know, a day or two before, we're just letting you know that we are going to go and contact this partner. They, under no circumstances, will be given any information about you. We will not in any way intimate or provide anything that would let them think that it was you. So the reason that we've left the time period, maybe left a month or 6 weeks, is that in the hope that there may be other sexual partners, so it's less likely that they're able to pinpoint who the index patient is. And remember that patients are motivated to provide information about all of their partners when they feel safe and supported, and understand why partner notification is important. There's lots of studies again that show that patients will often provide the information or the contact details of the partners that they believe are their index patient. So, or their source of their infection, sorry. So just remember that in my experience, almost 100% of the time they're wrong, but they'll say, oh, look, you know, you've diagnosed the person with, say, chlamydia. They say, I know exactly who I got this from. I got it from Joe Smith. And in actual fact, of course, we can't tell the index patient this, but you can go out, you can test Joe Smith and find that Joe Smith is negative and not infected. So there are obviously somewhere else that this patient has picked the infection up from, but patients will only tell you what they're comfortable to tell you. So the safer you can make them feel, the more supported you can make them feel, the greater the information that you'll elicit. And then remember that we need to reduce stigma. And I often would say to patients, this is very standard practice in all sexual health consultations and all sexual health assessments. Every single person that I speak to, I always ask them about partners. So this is nothing different, and let them know that it's standard practice. So we've got to think about the limitations of partner notification as well. I used to receive phone calls occasionally when I was working in the health department, asking me, a GP saying, you know, can you go and find the partners of my index patient? And I would say, okay, can you provide the information about the partners, and we'll see if we can contact them. And they would say, oh, but I didn't ask the patient. Aren't you the experts? Don't you know who the partners are? And I would then explain, well, I don't know who the index patient is, so how am I going to know who the partners are? And unless the index patient is willing to provide the information, how will we ever know who that person has had sex with? They are the only person who knows. So if they feel in any way judged or uncomfortable, then they will provide only information that to you as the health professional that they think is palatable or acceptable. We can't ever force or coerce anyone to provide information. So even when patients say, look, I have no idea, I don't know, I can't remember, I would thank them very much for their time and always leave the door open for them. Look, this is a difficult time for you. You've just had a diagnosis, you're getting some treatment. But if you happen to remember, often people forget, or they remember in a week's time or 2 weeks' time, I always would leave the door open for them. Please feel free to give me a call at any time if you remember a partner, and I will follow them up for you. People, I've occasionally heard from students who have said to me, oh, it should be compulsory. And I've always said to them, how would we police anything like this if it were compulsory or legislated? How would you ever be able to force somebody to tell you who they'd had sex with? So in motivating that index patient to carry out the partner notification, if we're talking about chlamydia, I would often explain to them the patient must understand transmission, because we only want to trace partners who are at risk. We don't want to be tracing people where there is no risk. So if it was non-penetrative sex and there was no risk of chlamydia being transmitted from one person to another, then I would explain that to the patient and say that partner we don't have to worry about. For example, if they use condom and lubricant and there was, only oral sex, then I'd say there's no need to follow up that partner. We need to find the next partner. And I also would always remind this patient that most STIs are asymptomatic. So people have STIs and don't know that they have them. I also highlight to my index patient why it's really important for the partner to know. In the case of chlamydia, we talk about if the partner happens to be female, then we talk about, consequences of untreated chlamydia for females. Very, very occasionally, when I've needed to motivate the patient a little bit more, I've also said to index patients that if they say that they're reluctant to tell their current partner, their current regular partner, then I explain to them that if you both don't get treated at the same time, then you might get your antibiotics today, take them, not have sex for 7 days and completely clear chlamydia. But if you have sex again with that partner who you haven't informed and hasn't had treatment, you'll just end up reinfected. So there are benefits for both here. Again, at this stage, reflective listening is a really important process to go through with your patients. So once you've explained transmission and you've had some discussions about who might be at risk and who might not be, then I would always ask the patient to explain it back to me, just to ensure that they got an understanding that this person, you're only letting them know that they've been at risk, you're not telling them that they're infected. And then I think this is one of the crucial elements that is often missed, is discussing with that patient the how-to of partner notification. So when I'd see a patient and say, you've been diagnosed with chlamydia, will you let your partners know? They'd say yes. And then I would say, so how do you think you might go about doing that? And then you could see that the patients would stop and have to think about that. What are your options? Do you live with this person? Are you just going to go home and tell them that you've had this diagnosis today and that you both need to be treated together? Or is it somebody that you've had sex with 3 or 4 months ago that you've split up with? Are you going to send a text message? Are you going to call them up? What is it that you're going to do? And are there any resources out there to help these patients? So there are some anonymous internet-based resources. Let Them Know is great for young people and people with STIs. That's the general population. Drama Down Under is specifically a website used by men who have sex with men, but it's only used for STIs, not for bloodborne viruses. And Better to Know is a website that was created and used for the Aboriginal and Torres Strait Islander communities. So I sent myself a text, let them know earlier this week, so I could copy this for you so you would be able to see. And this is the message, the text message that I got. So I went into the Let Me Know website. I put in my name as the partner. I put in my phone number as the contact, and I used chlamydia as the infection. And this is the message that I got on my phone. There's also expedited partner therapy, or what we call in Australia patient-delivered partner therapy, but it's only for chlamydia, and it can be used by doctors in a specific instance where they have diagnosed a person with chlamydia, and the patient, the index patient, explains that the partner doesn't have any way of coming in to see the doctor or to get access to health services. So this could be someone who works offshore, or somebody who, works strange hours and isn't able to get into a GP during regular hours, or so on. And in those instances, there are guidelines now from the health department that advise GPs how they can write a prescription for their index patient, and then also write a prescription for the same treatment for the partner without having seen the partner in a consultation. So just remember that this is only a guide. These are just ideas for you to think about. Partner notification needs to be undertaken, obviously. We all have our own different cultural context and background, and we need to ensure that the options that we're offering to our index patient are culturally safe. And the approaches need to be tailored to every single individual patient, because every circumstance is always different. So think about young people living in rural and regional communities. They think that this is social suicide, so we need to be very careful that they understand and ensure that that they know that this can be done anonymously. Now, very quickly, in the last sort of minute or two, we'll go on to provider, just giving you some ideas about how to do this if you're ever asked to do it yourself. So remember that it's our responsibility around confidentiality. I've covered that. Do not, unless you're required by law, disclose any information about the index patient to the partner. Only those partners where your index patient has provided the information are contactable. They only can provide what they can provide. And again, the intimate partner violence needs to be considered. Some concerns of health professionals are that if I contact this partner and they're not a patient of mine, they'll just think this is a scam. So how am I going to get past that? And they also wonder about that confidentiality in a so-called monogamous relationship. And I've already discussed that provider referrals perhaps not the most appropriate strategy to use. And so the ways that you can contact these partners are either in person, which is very rarely done these days. We used to do all of our provider referral in person, knock on people's front door at tea time. This was pre-mobile phone days. That shows you how old I am. But now most of it's done through phone conversation. I very rarely would send a text. And if I did send a text, it would be to the partner saying, my name is Jane. I'm a health professional. I've got some important health information I need to talk to you about. Can you please call me or give me a time I can call you? Particularly if people don't pick up a blocked number, and I would always call from my blocked number. If I had to send it in a letter, same thing, just inside the letter in case somebody else in the household opens the letter, I would use a plain envelope, and then inside I would use letterhead so they can see it's an official letter from either a clinic or from a health department or so on, and just says, please call me and contact me for a discussion. Email very rarely, but that's a good way to contact people who might be overseas. But remember that other people can read people's emails. And if in doubt, you can always ring the specialist service in the health department and get some ideas and some advice. When you're calling partners to inform them of their risk, just make sure you're prepared. So you're in a room that's quiet, you can close the door and you've got a few minutes. Don't do it on the hop, and don't do it when you're in a rush, because the partners may have questions to ask. And what are the sorts of things that you should think about? I always think about how I'm going to establish credibility in the first instance when I call the partner. So I identify myself, say where I'm from, and say that I'd like to speak about some confidential health information. And then I consider the partner's safety. Where are you? If they're driving a car, ask them to pull over. I once spoke to a young guy and he said, oh, I'm on the roof. I'm tiling a roof. I said, could you hop down from the roof and I'll call you back in 5 minutes? So just to be sure that the partner's in a place where they'll be able to hear the information, but they're safe. Don't do partner notification 4:30 on a Friday afternoon when all the services in your town or locally are shut, because partners do tend to, in my experience, they want to be tested as soon as they find out that they're at risk, particularly if it's something like HIV or syphilis. And they may panic. So just be flexible and think about it if you're going to do it on a Friday afternoon, not probably the best time to do it. What sort of information should you tell the partner? I usually just tell them what infection they're exposed to and tell them that somebody cared enough about them to ask me to let them know. The common questions that are usually asked by partners when you contact them is, often they're a little upset, or sometimes they can be a bit angry, or they don't want to believe the information, or they think it's a bit of a hoax. They demand to know the source of the information, like who is that index person, because I'll know if I've had sex with them or not. So just prepare yourself for somebody who's a little, probably slightly hostile. And I just keep reiterating, all I'm trying to do is pass on some information to you. I'm not saying that you're bound to do anything, but I just want you to know that you've had this risk and I can help you to get some testing. And if you've got the infection, to get some treatment. If you'd like me to do that, I'm more than happy to do it. But this is not malicious. Nobody's saying that you've got this infection. I'm just saying that you're at risk, and nobody's saying that you have transmitted it to anyone else. Somebody cared enough to ask me to let you know. And then, you know, if the person then says, yes, I'd like to come for a test, then I would raise the topic of their partners with them before taking the test, because I always found that during the consultation where you have to give somebody a positive result, particularly for HIV, then they will hear very little else in the rest of that consultation. So you don't want to be saying, very sorry to tell you that your diagnosis is positive for HIV. Now, can you tell me about all your partners? Because it's just not the best time for them or for anyone else. However, if you find yourself in that situation, which I did a few times, particularly with people who were backpackers, who were, you know, I'm jumping on a plane to go home to Europe tomorrow or whatever, then I would spend a bit more time with them to sort of let them acknowledge their diagnosis, you know, maybe a cup of tea or whatever, 15, 20 minutes, and then raise the issue of partners if there was anybody, or even a way that I could communicate with them. These days it's much easier with the internet and so on, so that I could follow up any partners in Australia that might have been at risk. Remember that that partner becomes an index patient and you start the whole process over again if they're diagnosed with an STI or HIV. And it's at that point, those partners that you've contacted and maintained the confidentiality of your index case will be most grateful that you did that, because they're now in that same position. Just remember, don't try to elicit information about partners in the presence of any other person. You know, many patients said to me, oh, you could talk to me in front of my husband or my wife or my boyfriend or my girlfriend. I can tell them about anything. And I would say, no, I need to speak to you on your own in the first instance. If you'd like to bring them in after we've had our initial discussion, you're welcome to, but I need to have that with you on your own in the first instance. And many a times when you did that, the patient would say, oh, thank you so much, because I didn't realise that's what you were going to talk to me about. And no, I don't want my partner to know that I've been at risk of a STI or HIV. So don't provide any information to your partners in the presence of anyone else either. And if they say why they can't bring someone in, you tell them that. Final point is that, as I said, contact tracing and partner notification is not a legal requirement in Victoria, although the Australian Medical Association believe that doctors do have a legal responsibility to notify their partners. So thank you very much. If anyone in any of the rural or regional health services ever want advice or support in setting up partner services, or even thinking about how they can integrate it into their general practice or anything, I'm always here, always happy to talk about partner notification and to support wherever I can. So thank you very much for listening. I hope that it's been somewhat useful.
Thank you so much, Jane. That was great. That was very thorough. And I learned a lot as well. Did anyone have any questions that they wanted to put into the Q&A or chat at this time? I think we've got time for a couple of questions if anyone had any. I guess something I was just thinking and reflecting on at the end around people thinking it was a scam, and post-COVID, the amount of scams that you get now with phone calls and things, people saying you've got this and that and blah, blah, blah. Do you feel like anecdotally, or even if you have evidence of partner notification being, I don't know, do you find that people are less responsive to electronic notifications these days?
Yes, and it's far better. That's why we never transmit the information electronically, except for via those websites where people can do it anonymously. But if you do go onto the Let Me Know website, it's a really interesting exercise. This was actually my PhD work. There's very clear warnings there around it being a criminal offence to use those sort of digital technologies maliciously or to harass or so on. And you get that warning 2 or 3 times as you go through the process of sending somebody a message. So they've tried to do that very clearly to deter them. When we very first set up Let Them Know 10, 15 years ago now, the first year when we were starting to evaluate it, we saw this massive, great big spike around February 14th, and people had been sending messages as jokes around Valentine's Day, and so we very quickly sought legal advice and some support from the Victoria Police around how we could prevent people doing that. We find very, very few malicious intent using those sites, but certainly contacting people, you've got to talk pretty quickly and you've got to convince them about who you are. And I found that can sometimes be difficult. And I would say to them, look, I'm going to give you a phone number of the clinic, call back, ask for me by name. So you've rung from out externally into the clinic, and, Melbourne Sexual Health Centre was part of the Alfred, so people recognise that. And they'd say, could I please speak to Jane Tomnay? And the receptionist would say, hold the line, I'll put you through. So by doing that, they can validate that. So if you're working professionally in a community health service or in a GP practice, that's one of the ways you can ask people to contact you. Many times, though, you hung up and said, will you call me straight back? And they didn't. So then you would be back where you started and you try again a few days later.
Yeah, that's interesting. An interesting challenge now, I guess, as opposed to when you first started this work, that people don't even answer their phone, or if you hear a voice you don't know, you hang up straight away. But yeah, that's a good tip to call back to the service for people who are operating out of a public health unit, for example. If no one had any more questions or any questions that they wanted to ask, like I said, it was very thorough, so I'm sure that people are digesting all of the information that you've provided. This session has been recorded and will be available. So if you did want to listen to it again for referral, or you wanted to recommend it to one of your colleagues to have a little listen, I think it was definitely a valuable session, chock full of information that, yes, hopefully people will be thinking about throughout the day and implementing into their practice. So thank you again, Jane, for joining us. That was excellent, and I hope that everyone enjoys the rest of their day.
Thank you.
Bye.
Bye.